All right, is that showing up normal?
Yes, I see it.
Okay. All right. Good morning, everyone. Today, we're going to be talking about brachial plexus injuries and their management. So I drew heavily from the ASSH modules and greens for this talk. Uh, First, we'll be talking about adults with lesions, largely secondary to trauma. We won't talk too much about the pediatric and the congenital cases. And to start off, we'll highlight relevant anatomy, then review frequencies of different injury patterns and statistics about um, our role and who is going to end up with these injuries most often. Next, we'll examine presenting deficits and how they help to localize lesions, in addition to the role of adjuncts such as EMG and advanced imaging. We'll go through these patients to see how they progress over time, as well as how and when we can intervene. So anatomy is always important, but focusing on the details is extremely important in understanding and treating brachial plexus injuries. 5 nerve roots from C5 to T1 give rise to 3 trunks. C5 and 6 contribute to the superior trunk, C7 to the middle trunk, and C8 and T1 form the inferior trunk. And then each trunk splits into anterior and posterior divisions, which reform into the cords named for their relationship to the axillary artery. The lateral cord terminates as the musculocutaneous and portion of the median nerve at the branch level. Here we're carrying fibers from C5, 6, and 7. Posterior cord carries fibers from all 5 nerve roots because it forms from all 3 posterior divisions and terminates in the axillary and radial nerves. The medial cord carries the inferior fibers from C8 and T1 to terminate in the remainder of the median, as well as the ulnar nerves. And this schematic shows a color-coded and greatly simplified breakdown of the nerve roots that helps conceptualize their function, how the root injuries will present. C5 is largely responsible for maintaining stability at the shoulder. With C6 is you have significant contribution to your ability to flex at the elbow. C7 for wrist extension, and C8 and T1 are primarily responsible for intrinsic hand function and via the median and ulnar nerves, intrinsic and extrinsic. Um, Keeping these things in mind, it's also important to consider other nearby structures. We mentioned the axillary artery running through the middle, but the clavicle overlying the divisions is shown here. Uh, previously is a common point of concomitant injury. We see clavicle fractures and any sort of um, apparent neurological deficit, brachial plexus injury should be um, highly suspected. Yeah, and it's important to keep in mind just how proximal on the extremity we're talking about when discussing plexus injuries. It's very high up in the arm. And you can't really appreciate it on this schematic, but the T1 sympathetic ganglia are much more closely associated with the T1 root than you can see at other levels. And its involvement in injury can assist in localization as well as we'll discuss a bit later. So the vast majority of plexus injuries occur secondarily to blunt trauma or traction injury, with over 90% being closed injuries. And a much smaller contribution is there from lacerations and gunshot wounds. Most of these injuries happen in motorcycle crashes, as violent mechanisms lead to nearly a 15 to 1 male predominance in patients that we see with plexus injuries. 90% of the injuries occur proximal to the clavicle and affect either the nerve roots or the trunks, with a slight majority of total injuries resulting in total paralysis of the extremity. The next largest subgroup of injuries involve C5 and 6 Erb's palsy, which these comprise about 1/4 of plexus injuries. Lower injuries to C8 and T1, Klumpke's palsy, are much rarer, in the order of less than 5%. Um, and if an injury to the brachial plexus does occur, it's more likely to be secondary to high energy mechanism. And um, in those cases, you have a high chance of affecting other systems. Now, 75% of injuries occur concomitantly with either intracranial, cervical, thoracic, or additional extremity trauma. And roughly 1/5 have associated vascular injury, which often will require repair. And granted, we'll ideally be seeing these patients after an appropriate trauma workup has been completed, but principles of assessing the ABCs and ultimately preserving life and limb are relevant concerns. Since these are trauma patients first, we should confirm these issues have been addressed adequately. Um, Compartment syndrome in a neuropraxically parasitic limb is not something that you want to be missing. Then we'll need to perform a detailed, focused neuromuscular exam to characterize the extent of injury. Remembering back to that simplified functional association of 5 roots is helpful, but you want a more structured way to document the injury as it presents and how it progresses, shown here where you're going through individual muscles to test their function. Um, in addition to characterizing the actual injury, it helps us see how they progress over time with repeating these exams. Um, Signs like the presence of ipsilateral rib fractures are important to note because that decreases the likelihood of successful utilization of intercostal nerves, as we'll discuss a little bit later, and any concomitant weakness noticed in trapezius may indicate further injury to, such as at the spinal accessory nerve level, which could also diminish our reconstructive options. So after identifying an injury, it's important to clarify whether the level of injury is preganglionic or postganglionic. With a preganglionic loss of continuity through avulsion, you have no potential for spontaneous improvement, as well as no good options for primary repair, given that the other end is the to be sewn to is the spinal cord. So some signs that point toward this level of injury can be determined acutely. These patients should have had chest X-ray at some point. There's ipsilateral. What's it? Uh, these patients should have had a chest X-ray at some point. And if you see ipsilateral elevation of the diaphragm, that signifies a phrenic nerve injury, which arises from the C3, 4, and 5 roots, um, and with other signs of plexus injury would indicate something being more proximal. We see winging of the scapula from paralysis of serratus. That will be secondary to a loss of the long thoracic nerve function, and could point to a C5, 6, and 7 root avulsion. As mentioned previously, the lower roots are closely associated with sympathetic ganglia, and ptosis, meiosis, and anhidrosis of Horner syndrome heralds their disruption. Because preganglionic injury disruption occurs at the level of information transfer from the central nervous system to the ganglia, there will be no Tunnel sign because the downstream ganglia neuron bodies are intact and functioning normally. Conversely, in advancing Tunnel sign, that can be used to monitor some improvement of a postganglionic injury as the axons regenerate. Bony injury involving foramina will also point toward likely injury of the root structures that travel through them. Um, in any case where there's no hope for spontaneous recovery, or if recovery is plateaued at an unacceptable level, and surgery is indicated. In the immediate post-injury period, if there's a loss of continuity that can be repaired, or root avulsion, that indication's been met immediately because we're not going to have regeneration through um, a discontinuous nerve. And if there are any open injuries, which we discussed is going to be rare with plexus injury, you want to be exploring that early on, if not even to perform the reconstruction at that time, but at least to assess the lay of the land, potentially tag structures um, for a more in-depth exploration later on. And if they're going to need vascular repair with the vascular surgery team, it'd be good to be in the room if possible to assess the situation. Obviously, that's not always um, um, a possibility. And classically, CT myelography was used to visualize these injuries, but these days, much more commonly, we'll be seeing MRIs to assess um, the modified anatomy following injury. After about 3 to 4 weeks, we can get good data from baseline EMG and nerve conduction studies to assess the degree of injury and remaining function after Wallerian degeneration will have reliably begun. In the case of a preganglionic injury, we'll have anesthesia, but sensory neuron action potentials will be recorded because the cell bodies within the ganglia remain intact. There's no downstream Wallerian degeneration. Of note, this does not apply for motor neuron action potentials because those cell bodies are located in the anterior horn within the spinal cord, and those axons will undergo Wallerian degeneration with either preganglionic or postganglionic injury. After about 3 months, often there's some level of improvement if this is truly is a neuropraxic injury. Um, Lack of any changes at that point and repeat EMG to see any progression will help demonstrate that there's a high likelihood of needing intervention. A notable exception to exploring an open injury early is a gunshot wound. In these cases, it's very highly likely that the nerves remain in continuity and are just neuropraxic from thermal or distraction injury. And it's warranted to wait at least around 4 months to monitor for improvement. Around 6 months, we're coming up on the end of the golden window for nerve reconstruction. Some recent studies have shown preservation of end plate function even up to about 18 months. But as we pass about 6 months, recovered function with the nerve-based reconstruction begins to drop off notably. For late presentations in adults beyond about that time frame, nerve reconstruction is unlikely to be successful. However, there's no time limit on tendon transfer or and rarely free functional muscle reconstruction is employed as long as supple joints are available. And when supple joints are not available, we can offer arthrodesis at multiple levels to create the greatest level of functionality available with a non-dynamic arm. So the interventions that we have are based on the different functional deficits and how they affect our individual patients. It's important to ascertain what their functional needs will be. For instance, elbow flexion in a young person's dominant hand is going to have a relatively greater impact on their well-being than digit extension in an elderly patient's markedly arthritic hand. Or generally speaking, there's a hierarchy with which to prioritize recreating function. The ability to flex at the elbow and the patient's able to feed themselves is generally the highest priority. Instability at the shoulder complicates every other downstream movement in the extremity. So at least creating tonic stability there is um, extremely high priority and generally more important than restoring full abduction, rotation, and capability of elevating the extremity above the head. Um, Function of the hand is difficult to reliably recreate given the complexity of movements over relatively small distances and a fairly distant starting point from a neurotization standpoint. Also, there are static reconstruction options, such as arthrodesis, form stable post, and prostheses that are increasingly becoming more effective that can be employed. Um, Now, we're primarily focusing on techniques for recovering motor function here, but sensory losses in brachial plexus injury are not insignificant. And when feasible, sensory reconstruction should also be attempted to maintain at least protective sensation. Though it's important to remember that the best outcomes will be secondary to spontaneous recovery. However, that obviously isn't a possibility in many cases, so develop a sort of reconstructive ladder. When operative intervention is required, doing so earlier will work better. Fortunately, these two principles are in a bit of conflict, as the time spent observing for spontaneous recovery may be contributing to a relatively worse final result, and that balance needs to be carefully taken into consideration. In cases of sharp injury where the cut ends of the nerve can be readily identified, reapproximated, and repaired without tension, that's the optimal option with the best result. Um, However, cases like that are exceedingly rare among brachial plexus injuries. Um, Much more often, after appropriately resecting non-viable tissue, there will be a gap. This is usually true even with sharp injuries, and some authors recommend conduits with nerve gaps up to 3 centimeters in other peripheral nerve injuries. But brachial plexus will generally be using autografts such as sural nerve grafts shown here, because you can obtain about 30 to 40 centimeters of nerve harvested from each leg at the cost of paresthesia over a small portion of the lateral dorsum of the foot, um, making sural grafts an extremely attractive reconstructive options. Nerve transfers have become more common and shown good outcomes in part due to the relatively shorter distance that will need to be traversed for regeneration. Consider the decrease in distance with an Oberlin style partial ulnar nerve transfer, as seen here, for return of elbow flexion compared against sural graft repair for C6 rupture, is thinking that significantly greater distance that will need to be traveled. Um, that said, there's obviously a limit on how many nerves are appropriate to be transferred, and complicated repairs will often require a mixture of both grafting and nerve transfer. With transfers, you're robbing Peter to pay Paul. So obviously, you'll need to carefully consider the redundancy and function that you will be weakening, as well as the fact that patients will require cortical retraining to activate the desired functions based on the donor's former activity. As mentioned earlier, nerves from outside the plexus, such as the spinal accessory nerve and intercostal nerves, can also be donors, and neurotization when intraplexal transfer is not available. The double fascicular modification of the Oberlin transfer seen with Dr. McKinnon in order to restore elbow flexion that we alluded to before relies on isolating the ulnar fascicle that's applying FCU and using that to reinnervate biceps, as well as the median fascicle further distal and extremely supplying FCR to reinnervate brachialis. Note that in addition to intact C8T1 innervation, this will require cortical retraining because the patient is going to be generating flexion at the elbow by attempting flexion at the wrist. Next on the noted order of priority is restoring shoulder stability. Lost suprascapular nerve function can be restored with transfer from the spinal accessory nerve coming out of the cranial system and natively supplying trapezius. This will recreate the shoulder stability, abduction, and a bit of external rotation that's lost from supraspinatus and infraspinatus denervation. Cortical retraining in these cases is a bit less daunting because you're trading a relatively similar motion of scapular retraction for external rotation at the shoulder. And given that trapezius has multiple points of innervation, it does not cause total paralysis of the entire muscle. Classically, elbow flexion was restored solely by reinnervation of biceps, and more recent studies have shown comparable outcomes between single and double fascicular reconstructions. In this, brachialis function appears sufficiently redundant and forms the basis for a fascicular transfer from the muscocutaneous nerve to anterior interosseous for restoration of FDP and FPL function. With this transfer, it requires fairly extensive dissection for rib AIN within the median nerve to minimize the distance that brachialis branch will need to reach. Um, Distally in the hand, pinch and grip strength lost in rare low brachial palsies can be improved with harvest of AIN distally, which sacrifices PQ function to reinnervate the intrinsics. This is similar to the technique that's used in supercharging and babysitter procedures for ulnar palsies. Of note here, the ulnar nerve has significantly more fascicles than AN at that level, and that mismatch does lead to relatively poor outcomes than some of the other mentioned transfers when that is when used solely as a transfer as opposed to as a supercharge. Many have found these results to be insufficient and aim for tendon transfer or free functional muscle in lieu of or in addition to neurotization for hand function. Total plexus injuries with a flail extremity are obviously devastating injuries, and there aren't a lot of great options for these. However, as we discussed, the spinal accessory nerve, when uninjured, can be used as a donor. We also have the intercostal nerves, which comparably are weak, but something is exponentially better than nothing, or significantly better than nothing. Um, Musculocutaneous function, usually via biceps, is the top priority in these flail extremities, often with arthrodesis at the shoulder. And these patients will need to focus on um, if we're on deep breathing exercises to recreate some level of function when um, intercostal nerves are additionally co-opted to create um, that flexion. And again, the mismatch in neurons here leads to suboptimal outcomes, but um, using multiple nerves can address that a little bit. Um, a newer method described by Dr. McKinnon is combining neurotization of median nerve branches to FCR and FDS with PIN or 2-PIN and the radial branch of ECRB for restoration of extension at the wrist and digits at a negligible cost to wrist flexion. Redundancy of the branches to the FDS is confirmed intraoperatively to minimize donor morbidity, but in cases we did see some significant morbidity. Um, but these procedures are often used in combination with tendon transfers to provide static tonic stability, which will lead well into the next bit of talk, where we're going to talk about these tendon transfers, which have no limit as far as time, and these are generally the most appropriate option for delayed presentations. In these cases, patients have the benefit of immediate return of function after post-op mobilization, of course, and they too will require some degree of cortical retraining. In cases where some elbow flexion is preserved, this needs to be augmented. The classic Steinler procedures, about 100 years old at this point, can be used to just resite the flexor pronator mass more proximally on the humerus. But when there's completely absent elbow function, bipolar latissimus transfer, which was developed in Argentina in the 70s and shown here, can be employed by rotating the muscle on its neurovascular pedicle and then securing the origin of latissimus to the biceps tendon distally, reciting its insertion near the coracoid process proximally. This serves to both generate elbow flexion and provide a small degree of stability at the shoulder. Lepiscopo described another use of latissimus in combination with teres major to stabilize the shoulder. However, this is more commonly employed in children. For adults, transfer of the lower portion of trapezius with or without combination with other transfers is commonly described technique. The lower portion of the muscle, which is independently innervated and independently acting, can be elongated with tendon grafts and then inserted on the humerus to generate external rotation of the shoulder, as shown here. Wrist extension also provides a degree of finger flexion with supple joints via the tenodesis effect. This can be recreated in cases with preserved median nerve function by transferring pronator teres to ECRB. As injury pattern would most likely occur concomitantly with inferior root injury. And of course, we'll have weakened intrinsic hand function. And again, very difficult to recreate um, function of the hand sufficiently. So we generally target individual movements and functions, such as key pinch, which an option for recreation is shown here. And when you have intact radial nerve function, is elongating ECRB with a tendon graft and then rerouting the tendon around the metacarpal as a pulley to adduct the thumb, um, as shown here. Um, there's other parts of the body. Gracilis is a workhorse flap for free functional muscle transfer. And as you might expect, other reconstructive options are generally preferred, but with late presentations that lack appropriate tendon transfer options, free tissue transfer can be utilized effectively. These outcomes are generally inferior in some cases to the other described methods, but those methods are generally unavailable a lot of times when planning on a free functional muscle transfer. So here, we demonstrate generation of elbow flexion with a free gracilis that's neurotized to the spinal accessory nerve. Um, Coaptation of multiple intercostal nerves, as previously discussed, and total plexus injury is also an option in free functional transfer. Um, Rectus femoris and latissimus dorsi are also reliable options, and as is necessary during the reconstruction, the denervated muscle can be excised and removed to create space for these relatively bulky flaps. Um, and I was focusing, of course, on dynamic reconstruction, but arthrodesis is an option if we don't have other capabilities to, and the optimal position to fuse the joints, usually both the shoulder, elbow, and in cases even the wrist as well, will be based on that individual patient and their individual needs. Um, for the sake of time, I omitted the extensive hand therapy and cortical retraining that will be required postoperatively. But after we've performed these extensive procedures and given the person the capability of some return of function, actually utilizing it will be a long process that requiring fairly specialized ancillary staff. That's what we have to talk about today. Get ready for listening and any questions if they're available.
Great. Good job, Wilson. Appreciate that summary. It's a tough topic to cover in this short period of time. There's a lot of high yield stuff in there. I think the ability to map out the plexus is like at the resident level is important. So understanding which roots contribute to which trunks and then ultimately which nerves is helpful. There's a diagram in greens that kind of helps you basically draw the plexus out, which I always thought was difficult. That's pretty high yield from a board scenario, because they could essentially give you a pattern of muscles that are out and then ask you where the lesion is within the plexus. That's usually can really test somebody's knowledge of what's going on. Also, the ability to differentiate between pre and post ganglionic lesions is also pretty paramount. So the presence of ipsilateral Horner syndrome, the presence of diaphragm paralysis, or cervical paraspinals being out on EMG can help make that diagnosis between pre and post ganglionic, and that will help determine sort of the timing of intervention for some of these things.
I think the most important thing is, nice job, Wilson. The most important thing is exam, doing a thorough exam and trying to map out the level of injury. You can get that information by your exam and drawing a diagram. You don't always need an EMG to do that. I mean, obviously EMG is part of the workup, and so are other advanced imaging, but getting in a good exam can be quite challenging sometimes, particularly in the multi-trauma patient, but that's absolutely critical here, is getting a good baseline exam.
Thank you.
Does anybody have any cases for today?
I actually have a little presentation on a case. I can go ahead and go unless anyone.
Yeah, sure.
Yeah.
All right, so I did mine on hook of hamate fractures and their management. So case presentation from last week, we had a 19-year-old right-hand dominant male presented with acute onset of right volar hand pain and difficulty with grip. He felt like a pop while batting a few days prior to presentation. Relevant social histories: Division I baseball player, and on physical exam had edema and ecchymoses around the ulnar volar hand, tenderness over the hook of hamate, and full range of motion with all his fingers. Here's some of his imaging that we got from clinic. As you can see, that's on the carpal tunnel view. Have a hook of hamate fracture here. And in order to get back to competitive sports earlier, he elected for a surgical excision of the fracture. So just some fast facts about hook of hamate fractures. They're fairly rare in terms of all comer carpal fractures, only 2 to 4%. Most commonly injured with direct impact or batting sports like baseball or golf. It's common physical exam findings: pain with gripping, pain over the hook of hamate, ulnar paresthesias, as well as painful flexion with the fourth and fifth, or painful flexion with the fourth and fifth digits. It's often initially misdiagnosed or on the first visit, just due to low sensitivity and specificity of plain radiographs. And there's also a high rate of non-union due to limited vascular supply and watershed area at the hook of hamate. So first study I looked at was a retrospective case series in the Mayo Clinic in Rochester. Injuries spanned from 1998 to 2015. I really liked the study initially because they went over just like the limitations and initial diagnosis of the fractures. As I previously mentioned, there's low sensitivity and specificity for plain radiographs. The standard care is an initial carpal tunnel view for this, but this study, as you can see from the table right here, actually had a pretty low rate of detection from carpal tunnel views. So they suggested kind of have a low threshold for going to CT or MRI if there's a high clinical suspicion of a hook of hamate fracture through history and physical exam. So population, there's 51 total patients. There's 37 in non-operative management and 14 in an operative management group. They kind of clumped together a couple different ways in which they were managed. Non-operative included casting, splinting, and there are 3 even with no immobilization. And the operative combined both excision of the hook of hamate as well as fixation. And as you can see, the grouping of both the non-operative and operative patients were statistically similar, both or with age, sex, hand dominance, injured side, and mechanism of injury. So when comparing pain, range of motion, and grip strength of the non-operative and operative groups, there's no statistical significance between outcomes as well as overall pain scores and subjective returning to activity. So took this as, you could manage them both operative and non-operatively fairly well. Both pretty good options depending on kind of the patient's overall goals. One thing that I did want to note in the non-operative group, there were 12 total non-unions, 4 of which eventually required surgical excision outside of the study parameters. There is also no difference in pain, range of motion, or grip strength between the surgical excision and the fixation groups. A couple weaknesses of the study, however, because of the wide range of initial injuries from 98 to 2015, the mean last follow-up time was 73 weeks, but it had a pretty wide range. So there's definitely an element of like recall bias for the more distant reports. And also these numbers were only taken at one time post-operatively. So, there's not really a progression over time of how they did. It was just kind of one snapshot. So considering both operative and non-operative treatment plans were fairly equivocal, I wanted to look more into kind of parameters of the patient we had. So he wanted to get back to playing baseball fairly quickly. So I looked at a study that specifically looked at baseball players returning from this injury. So this was another retrospective case series of 41 specifically male baseball players, varying levels of competition, but there were a few professional, collegiate, and a couple high school players as well. These athletes all underwent excision of the hook of hamate and were released to kind of progress activities that tolerated it 2 weeks post-operatively. The median return to play was about 5 weeks, ranged from 3 to 7. And all players within the study were able to return to full activity. There was only one that needed PT, which was this guy right here in the bottom table that required repair of his FDS. All others were able to return without any PT. And there are only 2 that had pain at 1 year post-op, which both were attributed to sensitive scarring. Just quick overview of some surgical techniques. First, identify the hook of hamate using Kaplan's cardinal line in the ulnar side of the 4th digit. Once you identify that, it's kind of a zigzag incision. They emphasized creating a wide exposure, as there are several different vital structures within the area to identify prior to excision of the hook of hamate. It was recommended to work proximally to distally to initially identify the ulnar artery and nerve. And then as you move distally, identify the ulnar sensory nerve branch after the Guyon's canal, which moves ulnarly, as well as the deep motor nerve, which moves radially, as well as identifying the fourth and fifth flexor digits, then the ulnar aspect of the median nerve as it exits the carpal tunnel. And once all these structures are identified, it's important to excise the hook of hamate and then kind of debride for residual sharp pieces of the bone surface to make sure there's nothing hitting any of these structures following excision. These are my references. Any questions?
Great, thanks. Yeah, it's an unusual injury, but fairly, I'd probably take 1 or 2 out a year in our UVA baseball players. This case was a Tom Sox player who's in town playing this summer. But the standard is very, I get them back between 4 to 6 weeks pretty regularly to full activities. Once their incision sutures are out at 2 weeks, they can start doing more and more. But it's the sensitivity of placing the bat in the palm and the vibration of the bat from hitting that kind of limits them. They can get out into the field earlier once their wound is healed, but it's the sensitivity along the scar that may limit them from batting. It's also very important that you don't do this with a mini incision, because you should identify the ulnar nerve proximally, release Guillen's canal, and make sure you find follow the nerve, and because it's right there. And the chronic hook of the hamate fractures can lead to a late FTP of the small finger rupture. So ignoring these inactive individuals if they're displaced is not a good idea, and trying to treat them with cast management. If they're non-displaced, sure, you can try to treat them in a cast. And if they're not a baseball player or a golfer or tennis player, but a displaced injury can lead to a late FTP rupture, which is problematic. And when we did the case, you saw the FTP to the small finger was right there once we excised the hook.
Yeah.
Great. I think we're good. See you guys in the OR.
Thanks. See you.